A warm welcome to all participants and our esteemed panelists. It was a very difficult time during pandemic, but educating yourself does not stop here. With many advances in technology, we are here with the concept of online conferences and platforms to educate ourselves. So let us utilize this opportunity to educate ourselves. So with this positive note, let us start with a neuro session in Scientifica 2021 on cerebral palsy and the hip. We'll start with the first talk. I welcome Dr. Sandeep Patwardhan sir, a famous pediatric orthopedic surgeon. He has many research paper publication in international and national reputed journals on his name, and he is author for many chapters in orthopedic books. He is currently working as a PG teacher, head and professor of pediatric orthopedic surgery department in the Sancheti Institute for Orthopaedic and Rehabilitation, Pune, since 1999. But due to some unavoidable circumstances, Dr. Sandeep sir won't be available live with us. So he has provided us with his recorded talk on bone health in cerebral palsy. Rini.
And introduction, and at the outset let me thank the organizers of Scientifica 2021 for inviting me to be part of this program. My brief today was to talk about bone health in cerebral palsy. I am sorry that I am not able to participate in person because there is some other commitment, but I am happy to share my thoughts with you regarding the same. In cerebral palsy, I think the most important thing that one needs to understand is identifying the child into GMFCS grades. Grade 1 to 3, all of you know, are walkers, and ability to walk has got a very positive effect on the bone health. There needs to be weight bearing and a proper ability to swallow for the person to have adequate nutrition and a good bone density and good quality of bone, against which you can do good ambulatory skills. Typically GMFCS 4 and 5 children as infants have got deglutition issues. They have problems with swallowing and they have a lot of cough, recurrent URTIs, or sometimes even aspiration and pneumonitis, which makes them disabled and unable to perform their routine physiotherapy because they are chronically ill. So I have always often seen that if children are GMFCS 4 and 5, in young age, 3 years or 4 years, if we can offer them a peg gastrostomy, involve a pediatric surgeon, and do a peg gastrostomy and give them adequate nutrition in form of proteins, calcium, vitamin D supplements, as well as a good healthy diet, then their bone health definitely remains better and they don't suffer complications. Deglutition issue is completely bypassed with a peg gastrostomy, and that is very good because they don't get pneumonitis, chest infections, and usually they gain weight and then the parents are more comfortable feeding them rather than having a stress about nutrition. The second thing is that non-walkers usually will end up having disuse osteopenia, especially juxta-articular around the joints. But also being bedridden, they develop secondary contractures as they become older and taller. So on one hand you have low nutrition, second you have soft bones, sometimes rickets, third they are on medication. A lot of them who are on barbiturates or phenytoin or anticonvulsants, it is known that long-term anticonvulsants and neurological drugs cause osteoporosis and rickets. So all these factors have already made the bone soft in a non-walker. Now coupled with that, you have a young aggressive physiotherapist who wants to make a mark or prove his point or make the patient walk. So too much of aggressive physiotherapy in presence of contractures as well as soft bone and on neurological medication makes them targets for pathological fractures. At least 5 or 6 times a year I have to treat non-walkers with iatrogenically induced fractures because of vigorous physiotherapy. So I think target and goal setting is very important when offering therapy for non-walkers. You should make them trunk stable and ability to sit more important with upper limb use rather than ability to stand and walk. Of course, in GMFCS 4s, all attempts should be made to at least have assisted standing, because as I said, ability to stand and weight bear creates a positive reinforcement of the bone health. So the requirements of the first group, that is GMFCS 1, 2 and 3, are like any other normal child. They must take adequate white products, which means milk, butter, cheese, dahi, curd, apples, sitafal, all these things which have high calcium, and non-vegetarian food if they can. Not for vegetarians, they can take all the other, and paneer of course, so that they have adequate calcium and vitamin D intake. Also protein intake is important, and fresh fruits, so that vitamins, especially lime juice and citrus fruits, because vitamin C is also required. Protein requirement, and if you can take care of their caloric requirement, it is adequate and no special things need to be done. 4s and 5s need to be given adequate nutrition because they are susceptible to metabolic bone disease, being bedridden and being non-walkers and with their difficulty in swallowing. So sometimes you may have to step up the requirement, and also I would recommend in their wheelchair, put them out in sunlight for at least 45 minutes in a day between 11 a.m. to 2 p.m. where the UV rays of the sun will generate vitamin D in their skin. Most of them are indoors and bedridden and then suffer a lot of bone mineral health issues. Thank you very much.
Thank you, Sandeep sir, for such a enlightening talk on bone health that really help therapist. Now we'll go on to second talk for today. She's a well-known therapist, Dr. Asha Chitnis ma'am. She's a well-known pediatric therapist all over the globe. She is one of the favorites among students for her teaching skill and easy approach. She's certified pediatric NDT therapist and clinical director and founder of Vedanta program in Mumbai. Ma'am will be talking on therapy as a preventive tool for musculoskeletal health in cerebral palsy. Over to you, ma'am.
Good morning to everybody. Thank you, Sachin, for these kind words. At the outset, I thank the Sancheti Healthcare Academy and all my mentors and teachers who head your academy to invite me to this August gathering. In the coming 8 minutes, what I'm really going to speak about is, as Sachin said, therapy as a preventive tool for musculoskeletal health. What I'm going to really cover is basically understand what's growth and development in kids who are normal and cerebral palsy. What today is the plasticity and how do we understand about the musculoskeletal systems, which are common deformities that we encounter every day when we do kids with CP. Deformities are known to affect function, and can we really influence these deformities, and what the modalities are available today. I guess we all live in a great time of great change. You know what is happening with the pandemic and even as neuro rehab. If you really go to see, CP forms the largest diagnostic group of adolescents with physical impairment. And there are huge, exciting developments on neuroplasticity and musculoplasticity happening all over. And I guess research is really making us understand the mechanisms that affect cerebral palsy. Do we have a long way to go? And I guess that gives us the onus as therapists to understand what is our past and new information and how do we really integrate that. So just remember, as therapists, you need to have a lifespan approach, because if a child who's an adolescent of 20, 30 is a 3-year-old that you're treating today, I guess if you understand growth and development, you have rapid growth in infancy and early childhood, and actually all different body segments. So if you really look at a child at 1 year, the trunk grows well. The lower extremities is from almost 1 year to puberty. And again, at adolescence, you're really seeing growth of trunk. And growth spurts are already seen for girls at 12 years and at 14 years for boys. You need to understand that. And as I go further, I'll explain you why that is important. You already heard Sandeep sir speak that growth in cerebral palsy, that everybody has poor growth. He gave you a lot of causes of why they are. It's multifactorial. He already spoke on nutrition. It's hormonal. He already stressed so much on bone health and also neurological problems that we have. A lot of our kids who he explained about GMFCS 4 and 5 and adolescents are a lot overweight. Now understand that the constantly reorganizing brain and changing musculoskeletal system, everything that you're dealing with in kids is plastic, whether it's the neuroplasticity, whether it's your sensory systems, or it's your musculoskeletal plasticity. I need to explain to you that muscles plasticity in CP is what we know, and there is something that we don't know. What we know today is that maybe not present, the muscle plasticity in kids with CP is not present exactly as what I and you have. They say there's a lot of research, and Rick Lieber is talking a lot. He says that there is altered structural level which decreases muscle size. We have small diameters and highly stretched sarcomeres. Also, he says that the altered extracellular matrix and connective tissues are affected, and they have smaller number of satellite cells. What we don't know, that when and how do these negative changes in muscle occur? There is an evidence, if you read the DMCN in 2016, they say that there is a decreased input for corticothalamic and corticospinal pathways in preterm infants, and that definitely contributes to lack of muscle activation and hence muscle growth and development. The other point that comes out is, are these negative changes reversible or preventable? We yet don't know. And what can we do early, very early on, to really help this muscle grow well and develop strength? If you really understand the neuromuscular skeletal pathology in CP, it's a short muscle disease where there is a failure of long growth of skeletal muscle. Our kids can't relax a muscle, whatever tone they have. Their primary impairment is weakness. They develop over time thixotrophy or tissue-dependent stiffness. There is a change in fiber type and connective tissues, and hence the sarcomeres decrease in number, and hence we really look at deformities and contractures. The common deformities that you're really encountering as a clinical therapist, I see so many kids who have hip subluxations and dislocations. The prevalence is 55%, scoliosis is around 15 to 61%. Knee deformities are the largest that we see, and they're almost like 55 to 70%. Equinus and equinovalgus is 20%, equinus is 40%. And there is also an evidence of upper extremity deformities, which is around 65%. I guess the big question that comes to me as a therapist is, can I, as a therapist, influence deformity? Deformity is inevitable and it definitely affects function. The armamentarium that I have is this is conservative line of treatments where you do medications, you do bracing, you use adjuncts, you use splints, then comes Botox and casting, and then come surgical interventions that I think so that Dr. Jory sir would explain to us very well. One thing that I feel as therapists, we need to understand are growth, motor curves, and GMFCS and neuroplasticity. It's very well done that what you need to understand is level 1 and level 2, as Sandeep sir said, are walkers. To some extent, level 3 are also walkers, but by 6 to 12, there is definitely going to be a plateau and decline both for 3, 4, and 5. And hence, as a therapist, I feel your challenges in treating a child between 6 to 12 are great. Your goal settings have to be so very important. You need to start looking with the vision that a child at 6, if he's a GMFCS 3 or 4, what do you look at him at 12 or 14 years? A double whammy is that, unfortunately, or as the research that comes out from Canada, and Karen Pape says that 6 to 12 years also there is a little decline in neuroplasticity. So all these things really impact their lifespan approach and looking at how do we do it. For a therapist, I think so understanding ICF, understanding where your kid is and what your impairments, and understanding what outcome measures you use is very, very important. Having said that, we can't take away the role of early intervention and the implications of musculoskeletal spasticity. I work a lot in the NICU, and I feel Rick Lieber does say, and I also do agree, that just manual muscle stretching that we do in therapy really doesn't give you a lot of help. But if we can really understand and focus on changing the pathology of muscles is going to help. There is already an evidence that says that early as 16 days, you can see changes in the muscle. So some amount of active elongation and getting them to work and working on strengthening is the way forwards. We have to work on postural controls and develop a lot of eccentric and isometric work, get them to do balance and really coordinate each side of the body. Do not forget that strength deficit in C are huge. If I have to understand muscle muscle strength, three aspects to it at a different stage. One is endurance. That means how many repetitions that a child can do, how much is his anaerobic capacity, and what is his agility. We really need to look at this as we go forwards. So there are some activities that I say that I tell you, if you're really going to do basic strengthening using TheraBands is great. You can use some weights, but when I use weights, I'm very cautious about the muscle spindle and the Golgi tendon. So I love using weights when I'm doing aqua, but not on land. I do a lot of core strengthening and I give them a lot of agility exercises. Then coming down to universal exercise, this is great. If you really have this spider cage, it helps you to develop individual muscles, a great hand, extra hand. And it's very good when they're post-surgery, where you really have to really look at what muscles you're going to work on. There are lots of machines that are available and a lot of studies going on, and working with some adolescents on ice, getting a lot of frequency and getting lots of repetitions is good. You can have that. There is a lot of work done by Diane Damiano on this, and she really advocates a lot of strengthening interventions. There are motorized movement therapies for kids who are very involved, and that really helps a lot of strengthening. If you have kids who require upper extremity strengthening, there is Beta Glide that is available, which really strengthens them. Also helps you to do a lot of core strengthening. There is a lot of work on partial weight bearing and treadmill work. It does help. You have to be very choosy of which kid you're picking up, what's the speed of your treadmill and how inclined it is. It does help in kids with GMFCS 3 and 4 to give them loading and some kind of strength training. If you have fancy rehab centers, which we don't have a lot in India, but there is Locomat, and it does help you to kind of give them. But guys, remember, whether you do treadmill and whether you do Locomat, understand on the ICF how much you change that child's participation. By just doing Locomat, don't think that it will convert into he walking outside. So I guess you need to be very cautious and judicious of using this kind of adjuncts that are available today. As a therapist, never ever forget adaptive equipments. They are the first line to go. It gives me my alignment and base of support and center of mass, and it's useful. Look at every small thing. Look at a small chair that you're giving. How much can you get his alignment? What happens? What happens when you're doing a wheelchair? Can I get a proper seater just for him to function in school or at home? Very important. We heard Sandeep sir speak on bone health. I am not saying we need prone versus dynamic tender. Standing is very important. It increases bone health, mineral density, and please, getting a basic stander is very, very important, and I would recommend that. And please start doing that as 9 to 10 months when loading is required. Also, splinting, we don't have great evidences, but it does help to some extent, and it has a very positive, small positive effect, and I think so it should be looked at, and it should be used as an adjunct for a lot of kids with different kinds of splints required. I love extra pair of hands. I do sometimes taping, I do sometimes spears, I use teratogs. These are great. I also do CIMTs. It's really useful for kids, but you need to really be individualized, identify who's going to benefit. You just can't give it to everybody. Robotics is really emerging. The Armio spring is coming. It's very useful for kids with hemiplegia. It's motivating, it's learning, it has a lot of cognitive influences, and it really helps. There is huge evidence that they say that it is definitely improving, and it could be one of the tools to improve upper limb function as time goes by in the future. If I have to sum up my talk, I would suggest that neuroplasticity provides significant hope for future of persons with cerebral palsy. Current and future therapeutic interventions need to capitalize on this potential. If you're looking at kids who have potential problems or roadblocks for neuroplasticity cannot be accessed because of mechanical problems at contractures and deformities, take help, get them sorted, look what it is what we can do the best for children. Musculoskeletal plasticity may be positively manipulated with early and intensive interventions that influence both neural and muscle plasticity before negative muscle changes develop. And I'm reiterating, early intervention is the need of the hour, guys. We need to look at continued research, look at what's the new that is happening, and if we can ever manipulate negative changes in the skeletal muscle. And the more I read, I do not know, and I'm not someone who's an authority to speak on, but current evidences are emerging about medical interventions such as Botox and some lengthening procedures may do contribute to negative long-term changes in muscle. Please look at it. Every child needs to be individualizedly looked at and planned in treatment. I thank you, and I wish all of you a great Holi and a festival of colors. Thank you so much.
Wow, ma'am, that was a great talk. Thank you so much, Asha ma'am, for such an enlightening talk. That will really help a budding physiotherapist to know about preventive aspect of musculoskeletal problem in cerebral palsy. Thank you so much, ma'am. We'll move on to our third panelist now. Third talk, uh, Dr. Kishore Mulpuri sir. He is a pediatric orthopedic surgeon in Department of Orthopaedic at BC Children's Hospital, as well as the head of the Department of Orthopedics at University of British Columbia. His principal focus is on cerebral palsy and pediatric hips. He has many international publications on his name. Specifically, he will be talking on the hip surveillance. His topic is understanding the role of his hip surveillance in children with cerebral palsy. Over to you, sir.
Thank you very much for the very kind introduction. So the credit for this work and these slides goes to Stacy Miller, who's going to be talking after me. So briefly, objectives. I'm going to review hip displacements in children with cerebral palsy, and I'm going to describe the need for hip surveillance in children with cerebral palsy. And just following up on Dr. Asha's talk, and I couldn't agree more. She showed that pyramid quite nicely about the importance of therapy. So anytime I'm talking to any child or family with cerebral palsy, I talk about this 10 times 10 times 10 rule. So, if you multiply 10 by 10 by 10, you get 1,000. You take one away, you only get 1/10 of the result. You take two of those tens away, you only get 1/100th of the result. So a lot of us surgeons, we're megalomaniacs. We think we're God's gift to man, womankind, but we play a very small role. And I would humbly say 1% of the role and the overall result this child needs to get. So it's really a combination of the medical team, the therapy team, and the family and the child working together to achieve any goal. So I want to humbly submit that the role of therapists, and those of you that are here, is a very important one in caring for children with cerebral palsy. Hip displacements, you can see this is a graduate, the same person's x-ray as you see over a period of time. This hip has gone from a minor displacement to a full dislocation. So this happens over a period of time. So hence, this can be prevented if we have a regular screening program. What happens when we let it dislocate? You can see this femoral head will lose its shape and eventually will dislocate and become painful. And this can happen in all of these children that are able to walk, children that need aid, children that are in a wheelchair. As we know, the less is the mobility, the more common is the hip displacement, but it still can happen in all different degrees. So it's important to understand for anyone caring for children with cerebral palsy, very, very important to understand this classification system of gross motor function classification system. And as you can see here, the more mobile the child is, the less is the hip displacement, or in other words, the less mobile the child is, the more the child is in the hip, say wheelchair, higher is the hip displacement. And you can have almost a 90% chance that this child in a wheelchair is going to have some degree of hip subluxation that needs attention. What happens if you leave it alone? They become painful. There is reduced quality of life, loss of mobility, loss of range of motion, and requiring more complex surgery. There are several studies that are done that have shown that leaving these hips alone is going to cause a permanent disability in these children. Children that are already in wheelchair, they have a lot of pain and development of scoliosis and many other issues. And here's an example of a JMFCS4 and a 5 child. You can see on the 14-year-old JMFCS4, there's pelvic oblique fatigue, development of scoliosis. And in the 11-year-old, you can see with GMFCS5, both hips are dislocated and the cartilage on the femoral heads is gradually losing. And here is a GMFCS3, otherwise 2, in the sense this child was actually walking independently before and lost cartilage and ended up having a hip replacement so that this child can be mobile again. So there's no doubt now more and more reports keep coming out and showing that their health-related quality of life is grossly affected by hip displacement. What kind of treatment is required? It really depends on the extent of the hip displacement, secondary bony changes if they're present or not, the pain, age of the child, and obviously the family and the child and their decision to go through with the treatment. I'm not going to go into details. I'm sure Dr. Johari will touch upon this, but you can do a soft tissue release, or you can do a bony reconstruction, either just on the femoral side, or you can do both femoral and acetabular side. And so depending on the degree of severity and the age of the child, you can do different surgeries. And if you've left them too late and the cartilage is gone, you may have to do some kind of what we call salvage surgery. For lack of better words, I say this is a surgery no orthopedic surgeon likes. We cut the femoral head and throw it in the bucket. So it's not something that we like to do, but this is the last stop resort if we can't reconstruct that hip. So in other words, early detection is really important. And any surveillance program anywhere that people are planning needs to have enough resources to be able to treat this child. Otherwise, just simply doing screening is not going to really make a difference. And what is our experience? As you can see here, when we were looking at starting our program, really trying to compare where we were in 2008 to 2009, and we compared ourselves to a benchmark, which we used as Melbourne, and that had not necessarily a statewide screening program, but they had a hospital-based screening program with a strong advocacy for hip screening. And you can see that we were doing a lot more salvage surgeries and very, very few preventive surgeries. And aim of hip surveillance is basically you want to identify early indicators of hip replacement, right? And it is usually by clinical and radiological exam, and what's most commonly used is radiological exam, and which is just dependent on the frequency, which is based on the risk. And we followed, when we were trying to do our own, what's already been done. We used the Swedish experience and Australian experience into account, and we gathered 50 participants from around our state. And you can see it's a multidisciplinary approach where we have pediatric orthopedic surgeons, pediatricians, physiotherapists, radiologists, administrators, all came together. And then we came up with a guide that looked like this. And you can see clinical exam and x-rays, when and the frequency, as one would expect in GMFCS in 4s and 5s, the frequency is a lot more than the lesser GMFCS levels. And then we also helped Stacy and Maureen O'Donnell, one of our development pediatricians, led this ASC-PDM hip surveillance care pathway. And then based on that, we actually modified our own after a few years of starting ours. We do clinical exam. And as you can see here, we'll check for hip abduction and extension. We also see if there is pain on any clinical exam. And we also look in children that can walk if they have any hemiplegic gait. And it's important to understand how to do this exam. If you don't correct the lumbar lordosis they have, you might not get a good AP exam. So we actually advocate all our radiologists that do x-rays. And then we measure this ramus migration percentage, which is the amount of the femoral head that's inside the socket to the one that's outside. And then anything that is more than 30%, we watch them very closely, and we expect them to refer them to a children's orthopedic surgeon. And you can see here in British Columbia, even with discussion of starting a hip surveillance program, reduced our salvage surgery, And I'm happy to note now in 2021, we barely have had any salvage surgeries. We've almost eliminated full dislocations require salvage surgeries 5 years after starting our program. And lessons learned is time to start talking about it is now. Like this conference is really important for young minds, budding physiotherapists to know these children in wheelchair need to be screened. They're at highest risk for hip displacement. So importance is educate, educate, and educate regarding hip surveillance. And as everything would have a champion or a hero, for us in British Columbia, it's Stacey Miller. And it's kind of what Walt Disney said, it's kind of fun to do the impossible. Thank you.